chronic myeloid leukemia. So this is a very high yield topic, guys, for plab1. So what is CML? So basically, clonal stem cell disorder causing proliferation of mature granulocytes. Basically, excessive production of all stages of mature granulocytes. These are neutrophils, eosinophils, basophils. So the blood examination of the person suffering from CML will have elevated neutrophils, eosinophils, and basophils. All right. So for all the types of leukemias, such as CML, CLL, ALL, or AML, you need to know about the age group these diseases occur in. All right. So in case of CML, you know that the age group has to be 40 to 50 years. So any middle-aged person where you see a blood examination showing mature granulocytes of all stages, predominantly neutrophil axis, it's a straight giveaway for CML. All right. Okay. One more mnemonic for you guys is whenever you see an enlarged spleen in a middle-aged patient, consider it as CML. All right. You can remember it by CML has CMS. CMS is crazy massive spleen. Okay. One more thing, very interesting fact about the gene associated with Philadelphia chromosome. How I learned this fact was that basically Philadelphia is a place where we see a maximum population being in their middle age, right? The people who are in their middle age are more susceptible to chronic myeloid leukemia. So that is how you correlate CML with Philadelphia chromosome. I hope it is clear. Now, moving forward, three phases of chronic myeloid leukemias, three phases or stages of chronic myeloid leukemia. So, first stage is chronic phase. So, remember, if a patient is suffering from CML and is in chronic phase of the disease, then remember that the patient is asymptomatic. That is, no presenting symptoms are present in the patient, but the blood examination would suggest of all the mature granulocytes. All right. Also, one more fact that more than 90% of patients are diagnosed in the chronic phase of CML just because this phase is the longest phase and the blood examination reveals the granulocytes. Now, second phase is accelerated phase. So, accelerated phase is basically a transitional phase going from chronic to blastic phase. It's a short-lived phase where you can see a transition of patient going from being asymptomatic to developing the symptoms of CML. All right. And your blastic phase, or you can say blast crisis, is technically a phase where you see excessive, proliferation of granulocytes. Now, in blastic phase, it's excessive proliferation. And again, note that it is neutrophil dominance. All right. You will see neutrophil dominance in the blood examination of the patient. Also, you will see a massively enlarged spleen. A massive splenomegaly will be seen in blastic phase and other symptoms, which we'll discuss now. Okay, so these are the symptoms, clinical symptoms that are very prevalent in CML in the plastic phase. Let's see what these symptoms are. Fatigue due to anemia, weight loss, night sweat, abdominal discomfort. It is the commonest, most common symptom that you will see in a patient suffering from CML, which is enlargement of spleen. Again, CML is CMS, crazy massive spleen. Remember this mnemonic, guys. Okay, so splenomegaly is a very common physical finding. Also, hepatomegaly is there. Enlarged lymph nodes are rarely seen. Okay. Also, see that the question is mentioning a patient with a low grade fever or patient having gout manifestations. Although the answer would be CML, so you need to know that even gout and low grade fever can occur in CML. All right. One thing you might have noticed that fatigue, weight loss, and night sweats. All right. These are symptoms that are coinciding with lymphoma as well. The B symptoms of lymphoma, right? So B symptoms of lymphoma also have fatigue, weight loss, and night sweat. So how would you differentiate between lymphoma and a leukemia? So one more thing, I'll make it easy for you. Just remember for CML, if you see a patient in the middle age plus with a massive enlarged spleen, that is a clincher for you guys. All right. That is a straight giveaway that it has to be CML. Also, if you see a patient with all the B symptoms plus, tender lymph nodes or rubbery consistency of lymph nodes, most likely right supraclavicular or cervical lymph nodes, lymphadenopathy. So, that is a giveaway for a lymphoma. I hope this confusion is clear. I remember there was a question in November 23 exam where it was very difficult to differentiate whether it was a lymphoma or leukemia because they had given all the B symptoms and at that time age was the differentiating factor that could lead to the diagnosis because it was a young patient, so it is very unlikely that he would be suffering from a chronic myeloid leukemia. Okay. Okay, now moving forward, chronic lymphocytic leukemia, which is another type of chronic leukemia, most commonly seen in elderly patients above 65 years of age. So, once again, I would like to highlight this fact that you guys need to know about the age group of every, which is related to every kind of leukemia. All right. So, just remember, chronic myeloid leukemia is for middle aged, and chronic lymphocytic leukemia is for the elderly above 65 years of age. Okay, let's come to the clinical features. They suffer from anemia, lymphadenopathy, and recurrent infections. Okay, one more thing that you would be noticing here is elevated WBCs. Now, you would ask me this question that although the patient has elevated WBCs, why would they develop recurrent infections? Because WBCs fight against the infections, right? But you see this bracket, although the WBCs are elevated, but they are dysfunctional. So you see a dysfunctional elevated WBC count. The WBCs are elevated, but they're not functioning well. So this is giving the infection a chance to attack the body. So recurrent infection due to elevated dysfunctional WBCs. Then next point is B cell lymphocytic predominance, which is very characteristic for CLL. And on blood smear, you will see smudge cells. So these are your clinchers, guys. One more important point about CLL, which is the take home message for you guys. It is the most common kind of leukemia which is associated with HIV patients. All right, let's move forward. Okay, acute lymphoblastic leukemia, ALL. Acute lymphoblastic leukemia is most commonly seen in younger age group, which is children up to the age of 15. You can see a characteristic pancytopenia in the patients. So, what is pancytopenia? It's a characteristic triad of anemia, recurrent infections, and thrombocytopenia. All right. And bone marrow aspiration shows numerous blast cells. So, remember these points. This would be the differentiating point between a chronic leukemia and an acute leukemia. All right. If you see bone marrow aspiration showing numerous blast cells, it's a giveaway that it has to be acute leukemia. It's either acute lymphoblastic leukemia or acute myeloid leukemia, right? AML. But if you see pancytopenia and numerous blast cells, close your eyes and mark ALL. That's it, guys. Nothing else to see. Okay, in exam, if you see pancytopenia, it's either ALL or aplastic anemia. Moving forward, acute myeloid leukemias. Acute myeloid leukemia most commonly seen in adult age group, mostly 20 to 30 years of age. The young adults. You can see acute myeloid leukemia in them, and their symptoms are very similar. They also have anemia, thrombocytopenia. You won't see pancytopenia in them. Okay, you will see gingivitis. Gingivitis is a common presentation in acute myeloid leukemia. You can also see blood films showing or rods, which is again a characteristic feature of acute myeloid leukemia. And bone marrow aspiration shows numerous blast cells, as I had mentioned earlier. Okay, coming to lymphomas. Okay, what are lymphomas? Lymphomas are basically lymphadenopathy, weight loss, and B symptoms. So, what are B symptoms? B symptoms are very characteristically noted here: unintended weight loss, unexplained fever, and drenching night sweats. Now, I had mentioned again that these B symptoms are commonly shared characteristics between lymphomas and leukemias, but now you know how to differentiate them, right? So, type of lymphoma there are two types, Hodgkin's and non-Hodgkin's. Let's see what these are. Okay, Hodgkin's lymphoma. Hodgkin's lymphoma is basically a malignant tumor which is characterized by multinucleated giant cells. Okay, Reed-Steinberg cells. So Reed-Steinberg cells are multinucleated cells with prominent nucleoli. All right. But the most important characteristic features that you need to remember about Hodgkin's lymphoma are number one point is enlarged lymph nodes. All right. So there is lower enlarged lymph nodes in the lower leg. You can see them in supraclavicular region. And the characteristic thing about lymph nodes is that these are described as painless, non-tender, and rubbery. All right. Okay. Drenching night sweats and unexplained fever. We had already seen unintended weight loss. That is a characteristic. These are characteristic B symptoms. Coupled with enlarged lymph nodes, always remember that's a lymphoma. Pruritus, lethargy, include splenomegaly. Splenomegaly, yes. Coming to this point, now I had earlier told you that massively enlarged spleen is a characteristic of CML with B symptoms, right? But here you can see splenomegaly and hepatomegaly as well. So plab1 is a very superficial exam, and the only thing that they can challenge you with is confusing you and bombarding you with information in the questions, and they make those one-page questions so they can give you a patient with splenomegaly, with enlarged lymph nodes, and all the B symptoms. So you would get confused whether it's a lymphoma or a leukemia. But yet again, I told you that if there is an enlarged lymph node for plab, just remember it can never be a leukemia. It has to be a lymphoma. Most likely, they would confuse you between Hodgkin's lymphoma and chronic myeloid leukemias. All right. So that's a takeaway point as well. The one thing that you need to know about diagnosis is has to be excisional biopsy. Okay, that is your word, guys. You have to remember excisional lymph node biopsy is the preferred diagnosis of choice or investigation of choice for lymphomas. You are not concerned much about management because it's most likely chemoradiotherapy, so you're not concerned about that. Okay, this is how Reed-Steinberg cells look like. Okay, we have a picture. Okay, these are how your normal lymphocytes look, and this is how your Reed-Steinberg cells look. So I'm a kind of person who remembers things by visualizing them. So Reed-Steinberg cells look like those weird alien staring into your soul with their massively enlarged eyes. So you can see like all the other lymphocytes are normal. Okay, non-Hodgkin's lymphoma. So the only giveaway about non-Hodgkin's lymphoma are the kind of lymphomas that don't have Reed-Steinberg cells. Now, what were Reed-Steinberg cells? They were multinucleated giant cells with a prominent nucleoli, right? Now, if in the question they give you irregular nucleated cells with uh, irregular nucleoli or non-prominent nucleoli, so that is how they are telling you that the cells are non-Reed Steinberg cells. All right. Not straight away tell you that these are non-Reed Steinberg cells. They would, do this wordplay with you. So most likely they are derived from B cells, and these are called as large B cell lymphomas. And again, you will see the clinical features, the B symptoms, characteristic B symptoms, fever, night sweat, weight loss, and all of these things you can see, which is common with Hodgkin's and non-Hodgkin's. Okay, quickie quiz times. A 18-year-old boy presents with a lump on his neck, which has been enlarging in size over a few weeks. He feels fatigue and describes frequent night sweats. He also has been told by his family members that he looks thinner over the past month. He denies recent travel. On examination, he has a 3 centimeter non-tender lump on his right side of the neck and an enlarged spleen on abdominal examination. He has a temperature of 38.4 degrees centigrade. So, what is the most likely diagnosis? Okay, so this is the typical question I was talking to you about. So, these guys are trying to confuse us with all the information that they can bombard us with. So, you can see the characteristic fatigue, night sweats, as well as 3 centimeter non-tender lymph node in the right side of the neck, which is the right supraclavicular lymph node, and an enlarged spleen. Also, you can see a mild elevation in the temperature, which is 38.4 degrees centigrade. So, but one thing that I told you guys is to rule out the question. So, age group is showing us that he is, in that kind of a age group. He's towards a young adult age group. So, it can't be CML, it can't be a thyrocloster cyst, it can't be HIV, it can be ALL, or it can be Hodgkin's lymphoma. So, based on the age group, we have ruled out CML. So, it can't be CML. So, our two confusing options can be either ALL or Hodgkin's lymphoma. Now, why can't it be ALL? The answer is because of lack of pancytopenia. You can't see any manifestation of pancytopenia in the patient, right? There is no mention of thrombocytopenia. There is no mention of WBC count. There is no mention of what no, there is anemia. So only one category which is showing anemia. Fatigue due to anemia can be considered, but there's nothing else which suggests ALL. So our obvious answer has to be Hodgkin's lymphoma. I hope this is clear. On to the next question. Okay, let's see what the question is asking us. A 79-year-old woman presents with a 6-month history of fatigue, night sweats, and significant weight loss. She has a lower respiratory chest infection that has not yet improved despite 2 courses of antibiotics. On physical examination, she has a palpable lymph node in the left anterior part of the neck. Lymph node is firm and non-tender. Investigation shows hemoglobin of 100, which is pointing towards anemia, slight anemia. WBC count to be 22. Okay. Neutrophils to be 4.1, lymphocytes 18, eosinophils 0.31, basophils 0.18, platelets around 351. A biopsy of lymph nodes shows a thin sheet of large lymphoid cells with irregular nucleoli irregular nuclei, and a prominent nucleoli. Which of the following is the most likely diagnosis? So, most of the things given in this question is to confuse you. And if you read only the last few lines of the question, you will get the answer. A biopsy of lymph nodes showing a thin sheet of large lymphoid cells with irregular nuclei. Irregular nuclei. So, as I had told you that Reed-Steinberg cells seen in Hodgkin's lymphoma, they are technically binucleated, multinucleated cells with prominent nucleoli, right? But if you see irregular nuclei, that is a straight giveaway that it is a non-Reed-Steinberg cell. And the condition which is associated with non-Reed-Steinberg cells is non-Hodgkin's lymphoma. All right, I hope this is clear now. Let's move forward. Okay, the other options are not valid as well because CML, ALL, AML is not coinciding with the age of the patient. Age, you can see the patient is 79 years old, so it is not coinciding with that as well. So, next, moving forward. Okay, one more question. Okay, so let's see what the question is asking us. A 45-year-old man presents with fatigue. He is otherwise asymptomatic, and blood reports show the following: hemoglobin level of 82, WBC count of 132, platelet count of 550, and there was an increased number of neutrophils, basophils, eosinophils in the peripheral blood smear, showing all the stages of maturation of granulocytes. What is the single most likely diagnosis? So this is a very straightforward question, and I hope no one does a mistake if this question comes up in your exam. It has to be CML. Um, Everything was explained. You can see all stages of maturation of granulocytes, increased number of neutrophils, basophils, eosinophils. Straight giveaway, guys. It's CML. Also, the age group is matching with what I had told you. He's a middle-aged man with fatigue. So, yes, CML. Okay, one more question. Let's see what the question has asked us. 8-year-old child with recurrent throat infection. He feels tired and lethargic all the time. Petechiae is noted on his lower limbs. On examination, splenomegaly and gum hypertrophy was noted. Blood results show hemoglobin, which is 68, WBC count 7, platelet count 75, so suggesting a condition of pancytopenia. And one more thing you must have noticed is how they tried to, confuse us with gum hypertrophy and splenomegaly. So if a person who hasn't studied well, he might get confused with AML and ALL because they might be relating gum hypertrophy with AML. But those who have studied well and they have related age group with the different types of leukemia, they know that if it's a 8-year-old child, it has to be ALL and showing signs of pancytopenia. So it's a clear giveaway. It has to be ALL. I hope it's clear. Okay, coming to another topic which is very important. Here we have hemophilia. Okay, so what is hemophilia? Hemophilia is technically an X-linked recessive condition, typically seen in male patients, and females are carriers, rarely symptomatic. We will discuss how the complete cytogenetics of hemophilia works. I'm going to show it with a Punnett score as well. So stay tuned for that. So, what are the characteristic features that you see in hemophilia? Normal bleeding time and a prolonged activated prothrombin, partial prothrombin time, which is APTT, is elevated. Now, one more thing, guys. Nowadays, according to the latest GMC guidelines, bleeding time is no longer done. So, it is discontinued. According to the latest guidelines, they don't do bleeding time. So, they would confuse you with not giving you the bleeding time and just giving you the elevated APTT levels, which can either be hemophilia or von Willebrand. So that's how they confuse you. So even I will be explaining how to differentiate between von Willebrand and hemophilia as well. So hemophilia has two types of disorders, like factor 8 and factor 9 disorders. So and these levels are confirmed by diagnosis. Now, one thing that you need to avoid in hemophilia patients is avoid IM injections and NSAIDs. As a deficiency of clotting factors like dysfunctional clotting factors 8 and 9, so the patient would bleed, has a tendency to bleed. So that's why we avoid IM injections and NSAIDs, as they might lead to excessive bleeding, right? Okay, hemophilia A and hemophilia B. These are the two types of hemophilias that you need to be certain with. Hemophilia A is associated with factor 8, and in case of minor bleeds, you give desmopressin, which raises factor 8 levels, and major bleeds, you have to give recombinant factor 8. But for the level of plab, you need to remember that mostly if you are given both the options of desmopressin and recombinant factor 8 for hemophilia A treatment, you have to always select desmopressin. Desmopressin is given first, and you have to select desmopressin as the answer if both the options are given. If either desmopressin or recombinant factor 8 is given, then you can go for either of them. But if both are given, go for desmopressin. In case of hemophilia B, factor 9, all in case of all bleeds, you have to give recombinant factor 9. Why can't you give desmopressin? Because it has no value in treatment of hemophilia B. Let's move forward. Okay, now here's how you differentiate between hemophilia A and von Willebrand disease. Inheritance is different for both of these conditions. You can see a X-linked recessive condition for hemophilia A, whereas in case of von Willebrand disease, you see autosomal dominant condition. Bleeding time is normal in case of hemophilia A, whereas it is prolonged in case of von Willebrand disease. Prothrombin time is normal for both of them, and APTT level is prolonged for both of them. Since bleeding time and APTT are both prolonged in von Willebrand disease, and in case of hemophilia A, you have an isolated APTT elevation, but since nowadays bleeding time is has been discontinued, so they won't be giving you bleeding time in the question. So how would you differentiate, as prothrombin time and APTT are same in both the conditions, right? How would you differentiate? There would be certain clinchers in the question. For example, von Willebrand factor levels will be reduced in case of von Willebrand disease because there is a von Willebrand factor deficiency, and in case of hemophilia A, it would be normal. Or they would be asking you questions related to genetic inheritance. We'll come to that also. Okay, so these are the symptoms. Yes, this is also a differentiating factor for to to differentiate between the two conditions. Mostly, if you see a patient with hemarthrosis, that is swollen joints or bleeding joints or excessive bruises in the knees or other joints, so that is a giveaway for hemophilia A. Whereas see a patient with epistaxis or gum bleeds or mucosal bleeds, heavy menses, you can relate it more towards von Willebrand disease as well. But to be very fair, this is not a very reliable way to differentiate between the two, but you can have a fixed idea in your mind that, okay, these conditions occur in both of them. But if I'm getting a question which is strictly showing me a condition of hemarthrosis, so I can, put my bet on hemophilia A. Or if I'm getting a question with nosebleeds and mucosal bleeds, more kind of those mucosal bleeds, I can put my bet on one milligram. So that's it. Okay, we have a question here. A 4-year-old boy has a history of epistaxis. Prothrombin time, bleeding time, fibrinogen levels, and von Willebrand factor are normal. Activated partial thromboplastin time (APTT) was prolonged. So the question is telling us that there is an isolated APTT elevation in the patient, and all the other things are normal. So that is a very straightforward question. So the answer has to be hemophilia. Then it can't be one Willebrand factor because again bleeding time is given to be normal. So that's a giveaway. It's not one Willebrand. And other conditions are they are just to fill in the options. But the answer is hemophilia. Okay, one more question. If they have not given us a lot of information, they would be testing us based on what this condition can be, or what the mode of inheritance can be, the genetic aspect. So, a 17-year-old girl has prolonged bleeding from a routine dental extraction. Now, this might be either hemophilia A or it can also be von Willebrand disease. Her father and grandmother have experienced similar problems. So, what is the mode of inheritance? Now we know that hemophilia is an X-linked recessive condition, whereas von Willebrand disease is an autosomal dominant condition. Now, getting back to the autosomal dominant condition, okay, autosomal dominant. Autosomal dominant condition, first you will see, even if the patient, the father was affected and the grandmother was affected, right? Small a. So the capital A denotes a dominant gene, and the small a denotes a recessive gene. Okay, now we are talking about the first generation. This is the grandmother. Okay, just remember this is the grandmother. So and this was the grandfather. Now, in the question, it is mentioned that grandmother was affected, and we are considering an autosomal dominant condition such as von Willebrand disease, right? Von Willebrand disease is an autosomal dominant condition, right? And in the question, there is no mention of grandfather, so we will assume that grandfather was perfectly healthy. Hence, we have given all the recessive genes to the grandfather. Now, out of these, if we do the cross matching, okay, out of the four offsprings, two are affected. So even if an offspring has one dominant gene, the offspring would be affected. So considering this child to turn out to be a male child, and this is the father of the girl mentioned. Now, father also has the affected gene. So father marries a girl who is not having the genes. She's also perfectly healthy. So this was the father, right? Now, uh, father has a dominant gene and he is affected. And mother is healthy. So again, if you do the cross matching, which comes out to be very similar to this condition, right? So it can either be a 50% chance of the offspring to carry von Willebrand gene, which is the dominant gene, right? So this is what autosomal dominant inheritance looks like. So this can, so the girl which is mentioned in the question can either be this girl or she can either be this child. All right. So it is irrespective of the gender. But when we are considering a X-linked condition, X-linked recessive condition, we have to take gender into account as well. I would like to point out about X-linked recessive condition is that a father cannot transmit disease to daughter. All right. And a mother can transmit disease to son. But a father cannot transmit disease to son. Now, why is that? Let's break this down. Okay. Suppose, considering a scenario, okay. So, this is how the father looks like. Okay. He's perfectly healthy. And mother carries the or X-linked recessive gene. So this is how the X-linked recessive gene looks like in a mother. Now, showing the inheritance. So the mother is successfully able to transmit the disease into a male child. But mother is not able to transmit a disease in the female child because female here is acting as a carrier, but male here is acting as a diseased individual. Why is this? Because always remember, a male child receives X chromosome from his mother and Y chromosome from his father. Since it's an X-linked recessive condition, the diseased X chromosome that he's receiving from his mother is leading to the diseased condition. Whereas a female receives one X chromosome from her father and one X chromosome from her mother. That's why females are have more tendency to be a carrier than being symptomatic. I hope this is clear now. Forward. Okay, one more question. Okay, so a 4-year-old boy has a history of epistaxis, prothrombin fibrinogen levels, and von Willebrand factor are normal. Activated partial thromboplastin time (APTT) was found to be prolonged, and his blood tests show hemoglobin level of 112, WBC count of 5, platelet count of 250. And what is the most likely diagnosis? Again, it's a complete giveaway. You can see an isolated APTT elevation, which is hemophilia. Now, I hope you guys must, this concept is clear for you guys. I hope it is clear.